Okay, welcome everyone to our 5th Fall 2022 Implementation Science Seminar that we are hosting between the Department of Psychiatry and Human Behavior, Advance-CTR, and the Brown Alcohol Research Center on HIV. We're really happy to have you today, and for the first time, we are focusing on global mental health implementation science. So we're really happy to welcome Dr. Alethea Desrosiers, who is a new faculty member in the Department of Psychiatry and Human Behavior, and she'll be talking about applying implementation science to address the global mental health treatment gap. Dr. Desrosiers joined us in September of just this year, 2022. Her work focuses on implementation science in low and middle income countries. And so this has been really exciting for all of us here to learn more about how you do this kind of work. She's the PI of a newly funded trial funded by NIMH, which is a hybrid or hybrid, I'm not sure if it's a hybrid, it is a hybrid implementation effectiveness trial. It's an R01 project to investigate the implementation of an evidence-based mental health intervention delivered by teachers in Sierra Leone secondary schools. Dr. Desrosiers also has a Hilton Foundation Award to culturally adapt and pilot test an evidence-based mental health intervention delivered with entrepreneurship training to forcibly displaced Colombian and Venezuelan migrant youth in Colombia. Dr. Desrosiers leads an NIMH-funded R21 project, applying user-centered design to develop mHealth tools to improve delivery quality of a family home visiting intervention delivered by community health workers in Sierra Leone. So between the Sierra Leone context and the Colombia context, we're really excited to hear more about implementation science in the global mental health setting. So thank you, Dr. Desrosiers, for being with us today.
Thanks so much, Ronnie. I'm very excited to be able to share some of my research with this group, and thank you for that lovely introduction. So I wanted to start off with asking the question, why does implementation science matter in low resource and conflict affected settings globally? And hopefully throughout this talk, I'll present some rationale to kind of support why it's so important. I'll talk a little bit about the global mental health treatment gap and how implementation science can help address it. And then I'll share some research that's currently ongoing in Sierra Leone and Colombia. So to begin with, mental health disorders are common across the globe. In 2019, approximately 15% of the population had one or more mental health disorders. And unfortunately, mental health disorders are also making an increasing contribution to the global burden of disease. Again, in 2019, approximately 13% of disability-adjusted life years lost due to mental health disorders. And despite the pervasiveness of mental health disorders and their contribution to the burden of disease globally, developmental assistance for them tends to be quite low. As you can see from this chart, in terms of assistance for health areas, mental illness only received 0.4% of developmental assistance. And when we look at the situation in most low and middle income countries, the government expenditures are even lower. When you think about all of the different sorts of challenges that different low and middle income countries encounter when it comes to disease and other health conditions, natural disasters, conflict and violence, spending money on mental health is often a low priority. From this chart, you can see that particularly in the African region and Southeast Asian region, it's really low. So while we might have some evidence-based interventions available, their access and reach tends to be really low in lower and middle income countries. So this is where implementation science can really come in, because not only does it work to address this gap between research and practice, because many of us know that the process of implementing research findings into practice can be a very long one. It helps to think about how to address the wide-ranging implementation problems that contribute to the ongoing mental health treatment gap in lower and middle income countries. So some implementation problems that are quite common are things like limited numbers of trained service professionals, lack of delivery settings, poor access or infrastructure to access the delivery settings that are available, and limited government financing and poor policy structures to support mental health services. And when applying an implementation science lens, it's really important to think about how to apply implementation science right from the beginning of the research process. So really engaging with key community partners, stakeholders, community leaders, government officials from the very beginning, and working together to sort of co-create the entire plan is something that really, I think, is imperative in this when you're working in these types of contexts, and really anywhere when you're engaging with implementation science. I don't think this applies just to lower and middle income countries at all. So questions such as who's going to deliver the intervention? What's the ultimate fit with the patient population? Is it going to be acceptable and feasible by the time it's ready to be implemented in practice? What kinds of strategies might improve training and support supervision? What factors might mediate and moderate implementation outcomes? And then what types of designs can help examine implementation science research questions? So these are the kinds of things that need to be thought about right from the beginning if our goal is to really increase adoption and sustainment of an evidence-based intervention in a real-world setting. And as many of you might know as well, there are a number of theories, models, and frameworks that can guide implementation science research studies. These are grouped largely into a few different categories. One group aims at guiding the translation of research into practice. These are the process models. Then there are models that aim to understand and explain what influences implementation science outcomes. These are determinant frameworks, classical theories, and implementation theories. And then there are evaluation frameworks that aim to provide a framework for evaluating implementation outcomes. And there's no right or wrong for choosing any of the available theories, models, and frameworks. It's really just a question about context and what sort of fits with your research study design, your research questions, your implementation science strategy, and what's going to be sort of fitting your overall kind of research process the best. The model that I've used most often in guiding my implementation science research is the EPIS model. This is an implementation process model that guides the process of implementation. It involves 4 phases of the implementation process: exploration, preparation, implementation, and sustainment. And then it outlines factors in the outer context, which is more of like the system or organization system level or outside economic kind of overall political, social, cultural system. And then the inner context, which is more of the organizational level. And then factors that can bridge these two contexts, like community and academic partnerships, as well as innovation factors, which can also help sort of bridge this gap. An example of an innovation factor is applying user-centered design to try to increase the fit of an innovation with the system or organization or providers. And then there can be factors within the inner and outer context that affect your activities at any phase of the implementation process. I've also used Enola Proctor's evaluation framework to guide evaluation of implementation outcomes in my research. I found this framework is just very easily applied, and it's broad and can work in a number of different contexts, which is also a reason why I found the EPIS model quite applicable in low resource contexts. In Proctor's framework, the focus moves away from evaluation of just client outcomes, such as symptom levels or functionality, and extends the focus to service level outcomes and implementation outcomes. The key implementation outcomes proposed are acceptability, adoption, appropriateness, cost, feasibility, fidelity, penetration, and sustainability. And I'm happy to describe any of these in more detail later. Some of them are a little self-evident, but happy to describe more later. And then there are also different types of study designs that can guide examination of implementation science research questions. One common type of study design are the hybrid implementation effectiveness designs. And there are 3 types of these. In a hybrid type 1, the focus is on testing effects of a clinical intervention on clinical outcomes while just sort of observing and gathering preliminary information on implementation outcomes. So this type of study design might be used when you really don't have a strong evidence base for clinical effectiveness of an intervention, but you're already, kind of thinking about implementation outcomes and the challenges and barriers to implementation, and you might want to gather a little bit of information already on implementation. In a hybrid type 2, you're simultaneously testing clinical and implementation effectiveness. So typically there would be an intervention that already has an evidence base in one setting, but maybe you're going to test it in a new setting or with different delivery agents. And then in a hybrid type 3, you're testing an implementation strategy while observing and gathering information on clinical outcomes. So in a type 3, the focus is really more on the implementation and investigating implementation effectiveness and less on evaluating clinical effectiveness. You already know the intervention is effective in improving, let's say, mental health, but you really want to understand more about what's mediating and moderating implementation effectiveness and what types of strategies are going to help increase adoption and sustainment, for example. So that brings us to the first context that I've been working in and applying implementation science, Sierra Leone. So I'll talk a little bit about some of the research and how I've applied implementation science research to guide the projects there. First, I thought it'd be helpful to have a little bit of background about Sierra Leone. I think understanding as much as possible about the background and context and histories of these places globally where U.S. investigators might want to work is really critical. So Sierra Leone is a small country on the west coast of Africa, bordered by Guinea and Liberia. And it's a nation that's been plagued with a compounded history of adversity. The population is just under 7 million. The median age is 19. Sierra Leone has the 3rd highest maternal mortality rate in the world. It ranks quite low on the Human Development Index rank at 182 out of 189. The country experienced an 11-year civil war from 10-year civil war from 1992 to 2002 that resulted in massive population displacement and the recruitment of a large number of children into armed groups. And then while the country was still in a rebuilding area following the Civil War, they experienced a really devastating Ebola outbreak in 2014 and 2015. And this really created further constraints on the healthcare system because the deaths were disproportionately concentrated around healthcare workers. So it really compounded the impacts of the Civil War on the nation's infrastructure, economy, people, mental health, everything. And this picture also shows another adversity that Sierra Leone has experienced. In 2017, there was a really kind of atrocious mudslide that resulted in a number of deaths and kind of re-triggered a lot of mental health issues from the Ebola outbreak as well. And mudslides are common in Sierra Leone, but the one in 2017 was really quite devastating. And I think it's important to focus just a little bit on the population of youth in Sierra Leone, given that the mean age is 19. Sierra Leone's experiencing what's referred to as a youth bulge. Approximately 60% of the population is under age 25. Literacy levels are generally low. Only 51% and 40% of females are literate. Less than 30% are enrolled in senior secondary schools, which are like our high schools here. And completion rates of those enrolled in secondary schools are only about 43%. So there's really a need to try to better prepare youth in Sierra Leone to take advantage of educational and sort of livelihoods opportunities. Regarding the healthcare infrastructure in Sierra Leone, for a nation of just under 7 million, there are only 2 psychiatrists to serve the entire country and about 17 psychiatric nurses. So the country really is supported by this large foundation of community health workers. And these are people who don't have any formal training. There are no specific requirements other than a basic level of literacy. They're trying to enforce now a 7th grade level of literacy to qualify to be a community healthcare worker. And then you just need to be in good standing in the community in which you reside, and that's the community that you serve. There is a training to go through to help train community health workers to deliver basic services, but these are people who really are just interested in providing services and can go through the training and want to do this work. So as you can imagine, there are a number of problems in Sierra Leone related to implementation of evidence-based mental health services that help maintain this mental health treatment gap. It's been estimated in Sierra Leone that there's approximately 98% of the population with unmet mental health needs. There really just aren't formal services available other than at one psychiatric hospital that is only accessible to some people and really deals with more severe problems. So a few of these implementation problems I sort of hinted at earlier: lack of trained professionals, limited delivery settings, poor access to services, and limited government limited government financing and policies. So one strategy, implementation strategy to try to address some of these problems is considering alternative delivery settings for evidence-based mental health intervention. So this is one strategy that I've been examining throughout my work. And in Sierra Leone, there is an evidence-based intervention that's already been developed to address mental health needs of youth. This work was spearheaded and led by Dr. Teresa Battencourt, who's a professor at Boston College School of Social Work. And through her work with war-affected youth, she and another group of people developed the Youth Readiness Intervention, which was really culturally developed through community-based participatory research methods, but integrates core components from cognitive behavioral and interpersonal therapies. And the goal is really to sort of improve some of these transdiagnostic factors that are linked with a variety of mental health problems, such as emotion regulation and interpersonal functioning. And the YRI is a group treatment model that can be designed by a wide range of lay workers, so you don't need to be a highly trained professional to be able to deliver it. Some of the core components of the YRI are psychoeducation, developing emotion regulation and relaxation skills, cognitive restructuring, behavioral activation, developing communication and interpersonal skills, and then developing problem-solving skills. And the YRI was first tested in a randomized controlled trial in Sierra Leone's education sector, and the findings showed that youth who received the intervention reported significant improvements in emotion regulation and functional impairment compared to youth in the control condition. And they were also 6 times more likely to persist in school. So these were really important findings from the first randomized controlled trial. So here we are with an evidence-based intervention, and the next question was, what are some strategies to increase the reach and scale this intervention out now that we know that it could offer some benefits for improving youth mental health? And this was really the goal of the Youth Forward study, which is an MIH-funded U19 project. It's wrapped up now. But the goal of this study was to explore an alternative delivery platform of employment promotion programming to implement the YRI within. And in this project, we partnered with a German development company called GIZ. They wanted to roll out an employment promotion program across some rural regions of Sierra Leone and integrate a psychosocial competency component within that programming. So this was a perfect opportunity because here we were with an evidence-based intervention already tested in Sierra Leone to improve psychosocial skills and mental health. And we could offer more of an evidence-based approach to providing psychosocial competency training for GIZ. So this project was a hybrid type 2 implementation effectiveness trial. And in these aims, I've tried to also sort of map on what stages or phases of the EPIS model are related to each aim. And so I would say that a lot of the exploration phase happened before the project even started, and sort of involving raising awareness of some of the implementation problems and exploring potential project partners. There was a lot that happened before even getting into aim 1. So the primary aims here were to use an interagency collaborative team approach to scaling and sustaining the YRI. And I'll talk a little bit more about this in just a second. And then to identify internal and external factors influencing the integration of the YRI into the Employment Promotion Program, or EPP. And then finally, to examine clinical effectiveness and implementation effectiveness, as well as labor market outcomes, given that the intervention was implemented within an employment promotion program. So the interagency collaborative team approach, this was first developed and tested by Greg Ahrens within the child welfare system in California. This was the first time it was examined or explored or tested in a lower and middle income country. And the idea here with this approach is to remove reliance on outside expertise for training and supervision and develop more of a local knowledge base that can be more sustained over time, and try to address some of the issues with staff turnover and keeping all of the knowledge and expertise with intervention developers. So in the Youth Forward study, we trained a seed team to deliver the YRI in a pilot study, in a small pilot before launching the scale-up study. And then this seed team were the supervisors and trainers of a subsequent cohort. So the idea is that you build this knowledge and expertise of a seed team, and then they can lead subsequent trainings and supervision sessions. And so this is what we then tested out in the scale-out study. The Youth Forward study was scaled up across these 3 rural districts here you can see on the map in Sierra Leone: Kono, Kailan, and Koinadugu. Freetown is the capital of Sierra Leone over there in the west side. So as you can see, this is really a large region of Sierra Leone. And not only is it large, the infrastructure there is extremely poor. Even when in the best of conditions, the roads are poor, it's extremely rural. And when you get to rainy season, the roads actually wash out and they become closer to rivers. So it makes transportation and moving around quite difficult. As you might imagine, across a rural region like that, there are many places to lose impact with your intervention. You can have problems like few mechanisms to track and report quality of delivery, a lack of focus on fidelity, people quitting, things are too hard, and you sort of lose the expertise, and people sort of just start making changes, and you drift away from what the original kind of fidelity of the intervention looked like. And so this is one reason why we selected the interagency collaborative team approach to scaling and sustaining the YRI, because it's one way to try to address some of those implementation challenges that can affect impact and fidelity of the intervention. So some of the key components of the ICT approach were PDSA cycles, or Plan, Do, Study, Act cycles. So in each supervision session, supervisors would talk about any problems and think about what's a solution or a plan to test out to solve that problem. Then they go ahead and try out the solution. They'd measure the results of the plan or just sort of observe, see what happens, and then make changes based on those results. And then this cycle could be repeated until an effective strategy is found. And then this can also be shared, this sort of learning in PDSA cycles, both within sites and across sites. So this is the second component, the cross-site learning exchanges. So this way, any knowledge that might be gained or problems that are occurring in one site or in one supervision meeting can be shared with others and sort of encourage the exchange of ideas and solutions and problems. And just a little bit to see how the study design was organized. So it was a cluster randomized design, and there were, it was 3-arm control, employment promotion or entrepreneurship training. We sometimes called it only condition, and then the youth readiness plus the employment promotion program or entrepreneurship training. And then we had collected data at baseline after the YRI was completed. So the YRI was delivered first, and then after the entrepreneurship training was completed. And there's I think, 2-year follow-up planned soon, but that's not something I'm actively involved with at the moment. And then going back to our evaluation frameworks, just to illustrate briefly, the focus here is pretty evenly on clinical and implementation outcomes with the hybrid type 2 design, and data collection occurred at the level of youth, facilitator, and agency leaders. And again, this was also a mixed methods approach. So there was qualitative data collected to investigate those barriers and facilitators, and also on some of the implementation variables. And so the next phase of this research is to examine delivery of the YRI supported by mHealth tools in Sierra Leone's education sector. And this is the newly funded NMH R01 that I am just launching. So I'll share a little bit about what the project plan is, but we really haven't quite gotten launched yet, but I'm excited to make that happen very soon. So this is a hybrid type 3 implementation effectiveness design, because now we have already examined the YRI within Sierra Leone's education sector and its demonstrated effectiveness. So now we want to focus more on testing an implementation strategy and implementation effectiveness. So the implementation strategy being tested in this study is mobile-based versus standard supervision and YRI delivery by teachers within schools. So teachers will either receive a mobile-based supervision kind of process or standard supervision. And the aims of this study are to first examine barriers and facilitators to implementing the YRI, aided by the mHealth tools in Sierra Leone schools. And part of this process is going to be developing an implementation blueprint, which I'll talk about in a minute. Then the next aim will be to examine feasibility, acceptability, and fidelity to the YRI delivered by teachers receiving mobile-based versus standard supervision. Then we'll examine the clinical effectiveness of the YRI delivered by teachers receiving mobile versus standard supervision. We do want to still examine the clinical effectiveness to some extent, though it's not the primary focus. And then the fourth aim will be looking at mechanisms of YRI adoption and sustainment within schools, and specifically investigating some potential mechanisms of readiness to change and organizational climate or school climate. And another part of this will be conducting a cost effectiveness analysis and return on investment analysis. So regarding the needs assessment in AIM 1, this comes from the work of Kara Lewis and Kelly Scott. And we're going to work on developing an implementation blueprint to try to address and identify the barriers and facilitators to implementing the YRI within Sierra Leone schools. And so what we'll really try to do here is, again, engage with our stakeholders from the beginning. This will be teachers, principals, and Ministry of Education officials. And we'll bring them together and conduct the first needs assessment, key informant interviews. We'll do some mixed methods data analysis to try to see what are some of the main implementation barriers that are coming out of those interviews. And then we'll go through a process of assigning values to barriers and facilitators and trying to figure out what are the trade-offs and priorities and sort of rank them. And then the next process will be to select implementation strategies to potentially address the highest ranked barriers. And then hopefully together by the end, we'll be able to create this blueprint of identifying the main implementation barriers, the implementation strategies we're going to test, and then moving forward with trying that out and seeing how it works. This project also in the first aim involves a user-centered design process to sort of refine and develop the mobile supervision model. So we have an mHealth app that has been developed as part of another project to improve supervision and fidelity monitoring. And the goal here is to take what's working from that mHealth map and adapt it and modify it for the current project. And also figure out how to integrate WhatsApp as a communication and messaging platform to aid communication during supervision. The user-centered design approach that we'll use is a 5-phased approach. In the first phase, which is problem analysis, we'll engage teachers and YRI supervisors in focus group discussions to try to understand better what are their needs and desires and wants, what are for a mobile tool, what would work well for them, what are the constraints in their schools and with their time, and really try to understand sort of what their needs are. Then in the next phase, the design phase, we'll develop some prototypes of the tools. And then in the development phase, we'll conduct 2 user interface, user experience testing sessions where our stakeholders will just test out the prototypes and provide feedback. And then in the implementation phase, we'll try to address any bugs and glitches. And then finally, in the evaluation phase, we'll measure how it worked and see how, what the best ways to assess functionality for like ongoing use are. And one of the main things we want to try to improve with this mobile supervision model is the fidelity monitoring cycle. So I just wanted to touch on this briefly because it's sort of like it's been the standard for a lot of this research on evaluating evidence-based interventions and trying to uphold strong supervision, but it's actually quite arduous. And I think we need to keep thinking about ways to make things more user-friendly and feasible and acceptable if we really want to think about how people are going to continue to use them in practice in the real world. So the fidelity monitoring cycle typically involves either audio taping or directly observing YRI sessions. Then a supervision session is held either face-to-face or over the phone. Supervisors complete a fidelity checklist. Then they use that checklist to provide targeted supervision. And then the YRI facilitator is supposed to use this feedback to refine YRI delivery. So we really want to try to figure out some ways based on feedback and engagement of our end users to sort of co-create a process that might work better while still functioning to ensure fidelity to the intervention. Again, this will be a cluster randomized study design with schools randomized to YRI plus mobile supervision, YRI plus standard or control, and then we'll have 3 data collection time points. And in terms of our evaluation framework and our outcomes, the focus is mainly on the implementation outcomes, just gathering a little bit of information on clinical outcomes because it's still important to make sure that YRI effectiveness does not differ based on the supervision strategy. And then we are collecting data at the level of youth, teachers, or facilitators and principals. And that concludes some of the key implementation research in Sierra Leone. I'll move now on to the project in Colombia. This is actually a picture of graffiti in Bogota, which is well known for its street art. There's some really, really amazing street art in there that I wanted to just share one image for this talk here. And Colombia is a country in the north of South America, sort of the northwest coast. It shares a long, strong border with Venezuela, which has important implications for the migration of Venezuelans and some of the current, current situations of migrants and refugees in Colombia. And it has coastlines that range from Pacific to Caribbean, which is kind of interesting as well. In terms of Colombia's context and background, they've experienced more than 50 years of armed conflict and recruitment of children into armed groups. There were peace agreements in 2016 negotiated between the government and one of the primary militant groups, the FARC. But there is still violence among communities, and even former FARC members are at risk for political violence and attacks. There have been approximately 9 million Colombian youth and families impacted by the armed conflict and internal displacement. And then as I was mentioning, with the strong border of Colombia and Venezuela, Colombia has received approximately 2.5 million Venezuelan migrants and refugees. And they are really trying to come up with ways to give these Venezuelan migrants legal status and think about how to integrate them into society. So there are people in Colombia who have been internally displaced, and there are efforts for social reintegration of those people who have been victims of the armed conflict. And Colombia is now also working to address the social integration of the Venezuelan migrants. As you might imagine, both of these groups of youth experience mental health challenges, and these can get in the way of their economic and social development. And evidence-based mental health services really haven't been available for these vulnerable youth impacted by displacement. The government has initiated some policies, but access to those services, these community-based sort of psychosocial support services, are extremely poor. So there's definitely a lack of access and sort of reach and penetration, and also a lack of evidence-based services. So again, some similar implementation problems in Colombia that contribute to mental health treatment gaps, as we saw in Sierra Leone, even though they're quite different contexts. They've experienced some of the same problems. The lack of trained professionals in Colombia isn't quite as big of a problem as in Sierra Leone, but their reach is. So the trained professionals aren't really serving the communities, or at least enough of them aren't really serving the communities where these vulnerable people live. And so there's limited sort of access to the services, even if there are trained professionals. And then there's also this issue of buy-in. So there's a lot of lack of trust and low buy-in in services that are provided by, especially by the government in Colombia. So in the project that is ongoing right now, the focus is to adapt an evidence-based intervention, the YRI, for Venezuelan migrant and forcibly displaced youth in Colombia. So one strategy here is to take this evidence-based intervention that has shown, it's been developed for another context, but one that's also experienced conflict and displacement and economic turmoil, and try to adapt it for a different population. So this is a hybrid type 1 implementation effectiveness trial, because now we're adapting an intervention and testing it in a new setting. So we really want to focus on the clinical outcomes first. The aims here are to culturally adapt the YRI for both internally displaced youth and Venezuelan migrant youth, then to investigate the feasibility, acceptability, and fidelity of the YRI, which will be implemented within entrepreneurship training among displaced Colombian and Venezuelan migrant youth, and then to look at the effects of this integrated programming on mental health, functioning impairment, and also economic outcomes. For the adaptation process, which we've already completed now, this was guided by the ADAPT-ITT model, which I just wanted to share sort of the phases of this model. It sets up a nice method for adaptation. I'll also say it was quite labor intensive, and I think I'd love to hear anybody else's experience with this model or ideas about how to speed up or reduce the costs of adaptation, because we definitely encountered a lot of issues with it. But the idea is to first, to engage your end users through the whole process. This is based on community-based participatory research methods. We started with a needs assessment that involved key stakeholders in a community where a lot of internally displaced youth resided in Bogota, and also with the youth themselves. And we then worked on how to adapt the YRI for these youth. That was in the decision phase. Next, in the administration phase, we did some theater testing, which is testing out some of the adapted modules and getting further feedback, which we could then integrate into a first draft of the adapted manual. We engaged topical experts to provide feedback on the draft and then integrated their feedback. And then we trained facilitators and did a small pre-pilot of the adapted intervention. And one thing that came out of this process was that youth really wanted more integrated programming, that just providing some sort of mental health service in their community center, they weren't going to go. They didn't really, they kind of felt like we've had this, we've seen this already. What they really wanted was also vocational training, jobs training, more educational opportunities. Some of the key adaptations that resulted from the ADAPT-ITT process here were a Spanish translation of the manual, reduction to 10 sessions from the original 12 sessions. We replaced some of the metaphors that have been developed. Potentially they could fit for Colombia, but they have been developed in Sierra Leone. One example here was changing the metaphor of a pot of boiling water as a metaphor of sort of emotions boiling up and needing to monitor them along the way, to a pot of boiling chocolate, because that is something that's extremely typical in Colombia and apparently makes an even bigger mess if it boils over than water. So the youth really liked this metaphor. We reordered some sessions, and we introduced more mindfulness exercises, which they wanted. And this little animal here, and the title here, Jóvenes Capybara, is what the youth named the intervention. And the animal is an animal that is in Colombia that carries others on its back. And they thought this was a good symbol of what they wanted to show from this intervention for youth. So some of our key next steps here, we're currently going through a pilot of the Jóvenes Capybara intervention with a partner organization, Rebel Business School. And we've integrated the program within their entrepreneurship boot camp, which is a 10-day entrepreneurship training program. They focus also on vulnerable youth and have a really interesting model of entrepreneurship training. And we're doing the pilot first with Venezuelan youth to try to gain their feedback and test it out with them and make some adaptations to make sure that we have a broad enough intervention that it also fits with their needs and kind of experiences and is relevant for their cultural sort of context and background, in addition to the internally displaced Colombian youth. So after we finish up the pilot and the interviews with the youth, we'll integrate that feedback into a final manual, and then we'll launch a randomized controlled trial of the YRI within the Rebel program with both Venezuelan and Colombian youth age 18 to 30. And again, just briefly here, our focus is mainly on the clinical outcomes, gathering some preliminary data on implementation outcomes. We do still want to assess fidelity because that's an important outcome for us. And data will be collected primarily at the youth facilitator and agency level. So some key takeaways here. I think engaging the key stakeholders and community members throughout all stages of the research process is really essential. It doesn't just, I think, increase buy-in and sustainability. I think it's just the right way to go about research in other contexts now, and really sort of co-create a process and an experience. I think does a lot more for building sustainability. I think another key takeaway that I'd like to highlight is the possibility of integration of mental health services within alternative delivery settings to increase reach, leveraging train-the-trainer models, and building service delivery capacity among non-professionals. Again, this can address implementation problems related to lack of trained service providers and lack of access and reach. And then continuing to collect cost effectiveness data, because this can be one way to help influence decisions among policy members and government stakeholders to increase investments in mental health services and maybe even more importantly, integrated services for vulnerable populations. And that's it. Thank you very much.
Thank you so much, Alethea, for presenting. That was excellent. And, you know, even though I know about your work, this gave me such a better understanding of all the work that you do and the challenges that you face and in trying to do implementation science in low and middle income countries. We have several comments and questions that I'll just get started with. So going back to when you were introducing the EPIS framework, which I'm really glad you did because we haven't talked about that a lot in this seminar series. A person asks, how do macro level system factors engage with the EPIS model? And I'm not sure exactly what those macro level system factors are, but is there a way of determining the influence of macro level systems on implementation outcomes within this EPIS framework?
Yeah, I think it would be helpful to have an example of a macro level factor. I mean, I think when we think of the outer context, we think mainly about sort of like more like policies and government and sociocultural kind of factors. And so, I mean, I don't have an epi background. So I'm not really sure if there would be other factors that sort of extend beyond those that would be more macro. But I think, you know, I think there can definitely be sort of sociocultural norms and policies that aren't supportive of mental health that can, like just say in a case of evidence-based mental health interventions. And, you know, there can be strategies that can help sort of, I don't know, bridge that gap and increase awareness, let's say, in an exploration phase of the importance of investing in mental health services. And that's one way where I think bringing in some of the like data on costing can also be helpful. I'm not sure if there's like another macro level factor that I'd point out as an example for the outer context, but happy to hear other people's ideas.
Yeah, no, I mean, if this person wants to put something else in the chat about specific macro level factors, they're welcome to do so, and we can come back to that. Another question is related to your hybrid type 1 design that you were first presenting. And so you mentioned something about implementation failure can result in false negative clinical outcomes. And obviously in a hybrid type 1, you're just assessing the implementation context. So if this happens in a hybrid type 1, what do you do with this information? How do you handle this?
I just want to make sure I a false negative. Is that what the?
I'm not sure if you mentioned it or if this is just their words, but it's a question about how implementation failure. So it's maybe not some like the evidence-based intervention works, but how it's implemented leads to maybe a false negative clinical outcome. So in a hybrid type 1, where obviously the focus is on the effectiveness of the intervention, but you're just collecting the implementation context data, then how does that help you understand more about this, I guess, is the question.
I think the types of implementation outcomes that are focused mostly on in a hybrid type 1 are feasibility and acceptability. And so just gathering that preliminary information, if you understand, if you get, like, even if the intervention is effective in your research study on clinical outcomes, it doesn't mean that there's any structure to sustain it, or that it would be feasible, acceptable, or adopted by people later. Even if you have some data that it's working. I think that's kind of what we find in clinical trials over and over again. We might have an effective intervention, but we don't have any process to really keep it sustained in a real world practice setting. So I think just right from the beginning, having those kinds of things in mind, so you're understanding what are the barriers and facilitators here if this intervention is effective, or what do the patients think it's feasible and acceptable? Do the service providers think it's feasible and acceptable? What about the agency leaders? And then why? And so then maybe in designing the type 2 study, you can already have those factors in mind to sort of guide what implementation strategy you might want to test. So I think that's why it's important as sort of like a stepping stone in the process.
Exactly. Yeah, no, I agree with you. And just to go back to the first question about the macro level factors, this person was referring to financing. So you mentioned costs, but I guess more specifically around like how you might finance an intervention perhaps in the future.
Yeah, I think that's always a challenge, especially in lower and middle income countries. So we often have research funding to test interventions, or now also test their implementation effectiveness. But how do you work with policymakers or government or NGOs to try to, move around money or find money or get donors? I think that's a much more complicated question. I know in Sierra Leone, a lot of the donors kind of pulled out at one point, which is why they have such limited financing, and also priorities of donors can change. And so then where money goes depends on where the donors want it to go. And so it's definitely a big issue. And then also governments change all the time. Sierra Leone's going to have an election in the spring. It could disrupt everything. Colombia had an election last June. So far, it looks really promising, but we don't know yet how things are going to turn out. And so this constant turnover in the government also makes it really challenging. I think the EPIS model, going back to that model, I think almost like I've seen some iterations of it and adaptations of it. I think it could be a cycle that's also kind of repeated, or you go in different phases too. Like once you've gone through the phase once, you might be back to the explore phase again, because now you've gone through one process, but now you've identified all of these other kind of implementation problems. So I think definitely giving governments data on cost effectiveness and return on investment is one of the main ways, I think, to influence them. They need to know that their investments financially are going to bring a return on their money.
I think that's a really important point about the iterative nature of our frameworks and models, that things aren't necessarily as linear or cyclical as we think that they should be. And so it's important that even though it's framed that way, that it may not be the way it works in practice. And related to that, the next question is about asking you to explain what you think, sort of to explain more about the results from your YRI project, your study. So how were the implementation outcomes related to the intervention?
In which project?
The YRI?
So all of these involve the YRI, the
okay.
the school-based trial.
Yeah. I'm not sure which part they are.
Okay.
Let's see what they're referring to. The Bogota, oh, Colombia. Did you do a why? Did you talk about
Yes, that's an adapted YRI. Yes. So, I'm sorry, can you repeat the question one more time?
So, when you were presenting your results about the YRI, this person is asking, were the implementation outcomes, or asking more specifically, how were the implementation outcomes related to the intervention?
Okay, that's interesting. I mean, I think we haven't done, so first of all, we don't have any findings yet for that project. We're right now we're just doing the pilot right now. We're finishing up this week of the adapted intervention.
Oh, wow, that's great. Congratulations.
Yeah, thanks. So we're calling it Jóvenes Capybara in Colombia, and we're finishing up the pilot. So we don't yet have data on either implementation or clinical outcomes, and we really won't have that kind of data till we do the RCT, which we're slated to start that in April. But I think that's a really interesting question, and I think that there are ways to maybe consider, do certain outcomes like Fidelity influence any of your clinical outcomes? I think that's an important one to examine. Or is sort of like the acceptability of an intervention, is that influencing any of the sort of patient level outcomes or participant level outcomes, because maybe they'll be less engaged if they're not really liking the intervention, or maybe they're not showing up so much. So I think that's a really great question, and certainly the Fidelity question I'd like to explore. And there are probably other ways to sort of examine more if certain implementation outcomes might have an impact on clinical outcomes. I think that's a really interesting question.
And, I wanted to ask a question specifically about, you mentioned really a lot of challenges to doing this work, specifically in Sierra Leone that you mentioned, and that, implementation science is challenging no matter where you do it. And you talked about a lot of things related to the climate and the infrastructure of the country, et cetera. And I just wanted to know, when you're doing this type of work, and you mentioned the PDSA cycles that you need to use in the different regions, what tools already existed that you were able to use to understand these PDSA cycles as one example? Or were you in a position where whatever already exists in this field just really wasn't appropriate for all of the challenges that you are experiencing? And did you need to then create your own? How did that work for you?
There's definitely a lot of sort of adaptation and tweaking. So I'll give an example. It's not specifically related to the PDSA cycles. I think we've tried to draw mostly from whatever tools are available, but often that means either taking the concept and presenting it and then trying to figure out, okay, how is this going to work in this setting? Or, at minimum, if it's an actual more like physical tool or measurement tool, definitely translating it and, trying to culturally adapt it. But we had to make a lot of adaptations with the ICT approach, because typically it's between agencies, and we only had one agency contracted to deliver the intervention at the end of the day, because GIZ contracted the service provider, not us. So our vision was we would have multiple agencies that are contracted, and then the interagency collaborative team approach would be cross-site learning exchanges between the different agencies. Instead, we had to adapt that and make it more of a collaborative team approach, and the exchange was across different sites and across districts. So conceptually, it kind of the sort of modification can kind of make sense, if it's not different agencies, but it's across different districts where, things might really be, the situation might be different there. And it's still like a potential for a lot of breakdown of information, which can happen across agencies as well. And sort of like this lacking of sharing of lessons learned. So that's one example. I think there's a lot that needs to be done with just sort of trying to simplify and adapt for all of the strategies really in these settings. But that's one example.
No, that's very important. It's really illustrative of what the kind of work that you need to do. And we are at 1 o'clock, so we will close our session. So on behalf of Dr. Hannah Frank, who is the Associate Director of our Implementation Science Core, and myself, I'm really happy to have had you here, Alethea, and thanks to all of our attendees. And we look forward to seeing you next week for our final session on December 13th with Dr. Amy Nunn. So thank you, and we'll see you next week.
Thanks so much.
Bye.